Welcome everyone to today's webinar, Managing Interpreter Services in Public Health During a Pandemic, Part 1, with guest presenters Mateo Rutherford, Vanessa Foster, and Christopher Fan. I'm Eliana Lobo, and it's my real pleasure to be here with you today to host today's webinar. Before we get started, I just want to briefly review a few housekeeping items for everyone today. Number one, the session's being recorded, and the recording and slide deck will be posted on the NCIAC website. Everyone joining us today will receive a link to the recording via email next week. Regarding your certificates of attendance, everyone who attends the live webinar today will receive a certificate of attendance as long as you attend the full duration and are connected to the webinar on your computer or the GoToWebinar app. If you have dialed in to the webinar by phone and are not seeing the screen share, we'll be unable to verify your attendance and as such cannot issue the certificate. If you're viewing the recording of this webinar, please indicate code 9537. That's 9537 when requesting your certificate. Be sure to review the webinar policies on the website for instructions on requesting a certificate for viewing the recording. And our team will make every effort to issue your certificate within 3 weeks of receiving the request. Although I want to highlight that today is a panel discussion rather than a training, so this webinar has not been approved for continuing education units. Now, during the webinar, if you experience any problems with your audio connection, the best thing to do is disconnect the audio and then reconnect by using the options on this little control panel section that I've highlighted nice and big so you can see. Please use the questions box to submit any questions or comments for the panelists, and I'll share your questions and comments with the presenters during the Q&A period at the end. But please feel free to send comments and questions in through that box throughout the presentation. And now it's my pleasure to introduce our guest panelists. Up front, representing the West Coast, is Mateo Rutherford, who is the Manager of Systems and Technology for Interpreting Services Department at UCFS Health. Mateo holds a master's degree in biology from UC Berkeley and a master's degree in Spanish interpretation and translation from the Monterey Institute of International Studies. He teaches healthcare interpreting at CCSF, is a CCHI commissioner, a Spanish CHI, and participates on the California Healthcare of Interpreters Association Education Committee. Mateo taught molecular and cell biology at UCB several years while a graduate student, was a bilingual disease prevention trainer at the CDC for over 4 years, and has conducted several trainings on interpreting for genetic subspecialties throughout California. So, Mateo, I give it to you.
Okay. Thank you very much, Eliana. And let me go to my talking points here. So our topic today really is looking at what we do in the face of this once in a lifetime. And I think it's even really beyond once in a lifetime, because I know my parents' generation, they were not around for the 1918, 1919 pandemic. So it's really a very rare event. But what do we do in the face of that, in particular at large health centers with a very diverse population? So I'm just going to kind of give you the story of what some of the things that we've done at UCSF Health. Luckily on the West Coast, we've been fairly successful until recently at keeping our numbers low, and especially in the Bay Area. For those of you who know a little bit about the culture of the Bay Area, you know that if our current central government says don't wear a mask, everybody's going to wear a mask. And so our masking was very, very high. San Francisco and California went to very early stay-at-home orders. I believe it was March 13th when the mayor of San Francisco put in a stay-at-home order. It was about 10 days before the state actually put in a state stay-at-home order. So our task really was to immediately think about the health and safety of our interpreters, and that was kind of twofold. One is that we didn't want any of our interpreters, of course, to be getting exposed or getting infected. And the other fact was that interpreters are the perfect super spreaders because we're jumping around from ambulatory clinic to ambulatory clinic into the hospital. If we're vendor interpreters, we may be going to Kaiser and then UCSF and then doing another appointment at another hospital somewhere across the city or somewhere across the bay. So that was the kind of the two prong that we were faced with. One was in protecting our interpreters, of course, and the other one was, of course, keeping the virus from spreading. So this took a heavy lift from our management team at that time. Our interpreters were primarily working on site. We did have video interpreting available, but none of our staff interpreters were actually working on video. They were all working on site. So the order came from up above that all staff that could work at home must work at home. And we literally worked around the clock. Took us about 2 weeks until we got all of our interpreters up and running with the technology, with the equipment they needed. Several of them used their own equipment, their own computers, until we could get equipment. Needless to say, IT department was overwhelmed with requests for new laptops. Our telehealth team was overwhelmed, but really everybody pulled together, and we could not have done it without our IT and telehealth teams. So we had our interpreters working at home. Unfortunately, they were on multiple platforms. So they had their video interpreting platform. They had their soft phone, which is basically Cisco software so that you can use your phone through your laptop to take telephone interpreting calls. And then, of course, there were the pre-scheduled Zoom appointments that at that time we didn't have on-demand video interpreting service. We only had on-demand telephone interpreting service. So those were pre-scheduled for our interpreters. So they're managing 3 platforms. It's a lot of work, but really they all stepped up. And I guess if there was a silver lining, both our interpreters, ourselves, the management team, and a lot of the providers began to realize that with good quality interpreters, you can use video interpreting for a lot of these assignments that we thought would not be possible over video in the past. And it also, I think, quelled a lot of fears around video interpreting because our interpreters are constantly hearing from providers, I can't wait till you're back in my clinic. I can't wait till you're back here in person with me and the patient. So providers, of course, always are going to prefer in-person interpreting. So the other great thing that we had going for us is that our management team, we are all nationally certified medical interpreters as well. So we had Spanish and Chinese covered. So in those cases, end of life, goals of care, those situations where we really absolutely had to have an in-person interpreter, the management team was able to step in. We did have one Spanish interpreter who was not really able to work at home because of the situation with the kids being home from school. So he would come into the office and do video and telephone interpreting from the office. And he was available then to help support these these critical care in-person interpreting needs that we had. Our telehealth appointments, needless to say, pretty much the medical centers shut down. All appointments were shifted to telehealth. So our telehealth team saw an increase from 3% of our ambulatory clinic appointments pre-COVID to 62% of our ambulatory clinic appointments. And that happened over a period of like 3 to 4 weeks. So that was an extremely heavy lift for them. And we're talking about everything went to telehealth, including hospital rounds, family meetings, everything. So it quickly became obvious that we needed to do as much as we could to help the LEP patients get up and running on telehealth. So we did have to translate a lot of materials, not only telehealth materials, but other COVID-related materials. And of course, the management team was able to handle Spanish, traditional Chinese, and simplified Chinese. And then we reached out to our partner at UC Davis Health. They have a whole team of professional translators, and they covered our other languages for us. And Ileana, if you could pull up that website, I just wanted to show people the instructions that we created for our LEP population. So one of the first things we did was we translated the instructions for how to get onto telehealth visits from a smartphone and a tablet into our top 10 languages. And you can see them listed right below the image here. And if you scroll down a little bit, Ileana, you can see we have the instructions here for a smartphone and the instructions for a PC or Mac or a tablet. And you can click on the PDF. Those can be printed out, or the link can be emailed to patients. And that really helped get our LEP patients, helped reduce the disparities, because one thing is really clear, that the pandemic has really made blatant the disparities in healthcare, not only for our LEP patients, but also for our hard of hearing patients, because now they were faced with a telehealth appointment where they may not have the luxury of being able to read the lips or have captioning available. So telehealth, Zoom does have captioning available, and that was kind of a clear missing link that I think people weren't aware of ahead of time, that there is a large population of hard of hearing and deaf people who do not have access to ASL for communication. They may be latent deaf, or they were raised in an oral tradition and they never learned ASL. Regarding ASL, we didn't have any staff resources, so we quickly contracted with our local agency that provides us with ASL to move their interpreting services onto the Zoom platform for telehealth. And that has been very successful. So we could add ASL interpreters. I already spoke about our Zoom appointments had to be pre-scheduled. So one of the things that we noticed immediately with the pre-scheduled appointments, we've been moving away from pre-scheduled appointments to just on-demand appointments. And with Zoom, we had to go back to pre-scheduled appointments until we could get our on-demand video service up and running. We're currently piloting that service, and we should be ready to launch it sometime by the end of this month. But what we notice now is interpreters were sitting again in waiting rooms, waiting for patients and waiting for providers. They were just sitting in virtual waiting rooms instead of real waiting rooms. So we had to set a strict timeline of 15 minutes. If the appointment doesn't start within 15 minutes, then the interpreter will try to contact the clinic If they're not able to, then they will cancel that appointment, and the clinic will get an automatic email saying that, you know, the interpreter has to move on and take care of other patients and other providers. And it provides instructions on how to add a telephone interpreter to their appointment. Let's see, I think that's pretty much all I have at this moment. Have done a lot of other translation work. We've been also doing closed captioning and simultaneous interpreting over Zoom for patient education. Like I said, everything has gone remote. So so has patient education and webinars for our patients and population. We've been doing some webinars about how to safely open schools for patients and teachers and school administrators. And all of those we have been able to do simultaneous interpretation over the Zoom platform for both Chinese and Spanish. And I think that with that, I will stop and I will be available later for questions.
Very good. Before I introduce Christopher, Erin, do you want to run one of the polls?
Absolutely. So welcome everybody. We're going to take a little break and learn a little bit more about everybody who's joining us today. So you'll be seeing a poll on your screen here, and just like to first ask which best describes your current role or job title. So some of you might be wearing multiple hats, but feel free to submit your responses here. And it looks like everybody has had coffee this morning as the responses are coming in very quickly. We'll give you just a few more seconds to enter your selection. And if you have any trouble seeing this, feel free to just chat in and answer, and we'll see that through the questions box as well. Okay, looks like the responses are slowing down, so we'll close the poll and share the results. So we have 20% reporting as hospital staff interpreter, 2% hospital hourly interpreter, 13% agency interpreter, 26% freelance independent contractor, and 39% interpreter supervisor or manager. Excellent, thank you everybody.
Awesome.
And I think we can slide one more quick question in here as well. Let's do one more quick poll. So since the pandemic began, how is your team primarily working? Is your team primarily working on site, online, on the phone, combination of the above, or not working much at all? And if you're not one of the manager group and you don't have a team, if you want to just respond to this poll and how you are working as an interpreter as well. And again, lots of responses coming in quickly, so we'll give just a few more seconds to respond. All right, let's see what we have for our results. So 23% reporting on site, 17% reporting online, 5% reporting on phone, 50% a combination of all the above, and 6% not working much at all. Thank you, everybody.
Well, I'm getting ready now to introduce our next presenter, who represents the Midwest. Christopher Fan currently serves as the manager for languages services at Barnes Jewish Hospital, overseeing an exceptional team that ensures equitable care for limited English-speaking and deaf, hard of hearing patients at the Washington University Academic Medical Campus in St. Louis. The campus is comprised of Barnes Jewish Hospital, St. Louis Children's Hospital, and Washington University School of Medicine. Christopher also serves as a diversity and inclusion leader for Barnes Jewish Hospital and as an adjunct faculty member teaching social justice and human diversity at the Brown School of Social Work at Washington University in St. Louis. So Christopher.
All right. Well, thank you so much for that very embarrassing introduction. I know I wrote it, and it's still embarrassing to hear someone read it out loud. But thank you so much, and thank you for inviting me to be on this panel. Good afternoon, all of my friends on the East Coast, and good morning to everyone else. And I also would like to say Hanukkah Sameach to everyone who observed Hanukkah and is celebrating Hanukkah since last night. I'll take just a quick moment to share that I think Hanukkah may be especially revealing to us this year in 2020. As Mateo said, it's been quite the year for many of us. And I think what I've been amazed about, not only with my interpreters, my team, but also the 31,000 people who represent BJC Healthcare, not just Barnes Jewish Hospital, but our entire 18 HSO healthcare system. The story of Hanukkah is all about doing more with what you didn't think you had. And this idea of only having enough oil for one night, now burning for 8 nights. I've seen nothing but that tremendous work from our clinical staff to our housekeepers, to our interpreters, to our leadership teams, being able to somehow burn 8 nights worth of oil with only one night of volume. And so, I want to thank all of you who are listening here. I know the work that you are doing. I know the commitment you've made to patients, to family members, to the team members that you also support. So thank you. And think of this Hanukkah as kind of a celebration of your fortitude and your resiliency as well. So with that, I just want to jump in with a quote that I always like to introduce people with, even at my hospital when we talk about language services. And that's just simply, good communication is the bridge between confusion and clarity. One of the things that we do, and you can go to the next slide, and I'll just introduce really quickly what we're known for at BJH Language Services. We consider ourselves experts in communication. Communication is not just simply the words that come out of my mouth, or for our deaf and hard of hearing friends, the communication they do with their body, but it's also understanding the sociocultural, the ethnocultural, and many of the other ways that we communicate with one another that can create huge barriers with how we have patients and their family members trying to have the best and most empowered healthcare experience that they have with our clinical team members. And so we at Language Services, we have always prided ourselves on eliminating those communication and cultural barriers that threaten or negatively impact the healthcare outcomes of our patients and their family members. We do this, right? And even prior to 2020, we did this with a lot of pride by doing in-person interpretation. We purposely pull out American Sign Language away from in-person because we understand that a lot of people tend to think as interpreting as simply as the verbal. And so we like to call out our sign language team members and friends as something that's distinctively unique and powerful for many people across our region. Our over the phone interpreting, our video remote interpreting. We have added telehealth, as many of you may also have experienced, and Mateo talked about, and we have a robust translation services. And we can go to the next slide. And so, so these were the two real questions that we were faced during this pandemic. And as many of you may have saw in my headshot, that I also hold a master degree in public health. And so one of the main questions that public health professionals are always faced with is, how do you do the most good for the most people, understanding the risks involved with every decision you make from a health standpoint? And so the questions that you may see is just simply, what if you were in the patient situation during a pandemic, and what kind of care would you want? And that was the real difficult question that I think the leadership at Barnes Jewish Hospital and BJC Healthcare made, with the expertise of our clinical leadership and us at Language Services, as well as many of the other subject matter experts who were trying to make the best decision, not only for our team members, but for the communities that we serve. And just to piggyback off what Mateo said, Mateo is absolutely correct. For many of us, there was a two-prong piece that we had to address, and that was, how do you contain the virus, and how do you ensure the safety of your team members? One of the things we added as a third prong was simply, how do we also ensure service excellence to the communities that we believe are sometimes the most divested and underserved, at least in the Midwest and in the St. Louis region. We understand that the health disparities and the social determinants of health that impact our St. Louis region are exacerbated by language. We know that language in and of itself is a social determinant of health. And so what we had to add to our questioning was, how do we ensure that our immigrant and refugee populations, or those who are LEP or deaf, hard of hearing, still receive that exceptional health care that we have prided ourselves on, so that there was no inequity in health provision that we provided to our English-speaking patients versus anyone else. Because of that, unlike many of my colleagues on the East and West Coast, Barnes Jewish Hospital and BJC Healthcare, we chose not to shut it down in the sense of sending all of our team members home. We continued to do a modified of on-site, as well as utilizing our VRI and OPI capabilities, as well as standing up telehealth. And what was really pivotal about that is that that gave us a lot of maneuverability and a lot of agility in knowing how to deploy our 25 staffed interpreters, as well as our up to 400 agency interpreters that we contract with across our region, the ability to keep them as safe as possible, but also allowing them to really live up to, for many, the true reason why they chose to be interpreters, or at least in our region. And many of them, they were part of the community that needed that help. And they found it in themselves to be that, that cultural and language bridge for their own communities that they went home to every day. And they really wanted to step up and still be of service. And so we can go to the next slide. And so one of the things that we, many of the decisions we made, and this really was following these 4 principles of our healthcare system sees qualified medical interpreter as essential staff. We have fought long and hard, and we have advocated and have been accepted by our leadership teams that medical interpreters are clinical team members. They are just as vital as the patient care tech, as the nurse, as the physician who's in front of them, because if without them, there would be no communication, and there would be a failure in service excellence and a failure in health provision. And so, our entire healthcare system, really saw each individual health interpreter as essential to the healthcare and safety of our vulnerable patients and their family members. We also understood that our communities, we are quite a refugee resettlement population region. Many people don't know that about St. Louis, but we have quite the number of ethnically diverse people who call St. Louis and the region home. They see our interpreters as trusted and necessary members of their healthcare experience. I am sure many of you who are interpreters, have been interpreters, remember many patients who, without you, they may not have really gotten through much of that health appointment experience, because they look to you for that trust. Because for many of our refugees, at least in St. Louis, they've had terrible experiences, traumatic experience with healthcare. And for them seeing, one of our interpreters that they've known for 5 years, they've seen them for 5 years as part of their health team, without seeing them all of a sudden for their oncology appointment, for their dialysis appointment, that could have really triggered a traumatic event for them to have been left behind. And so, we understood that desperate need, and so we had to juggle that as well. We also knew that our interpreters saw themselves as critical to the patient health outcomes. We've had plenty of stories of our interpreters who have demanded wanting to be there for those patients. They see our schedule, they see the patient name, and they say, I have to be there for them. I can think of my Russian interpreters who have known some of these interpreters since all of them immigrated to the US, in the 80s. And they've been there, and they've just been one of their interpreters for 20 something years. And they know that they're hard of hearing, they're almost blind, right? They're just the elderly needs of some of our immigrant families. They really needed that person there. And so some of our interpreters just demanded to be present, to be part of that experience. And then finally, our department leaders, not just myself, but the supervisors that I serve with, my executive director at the time, and now vice president, my senior manager, we also dedicate ourselves to understand the physical, mental, and spiritual health of our own interpreters. And so one of the things that we did that we tried to do was we tried to make sure that they were properly supported from a PPE standpoint. We made sure that we ordered on our own budget. We didn't want to rely solely on our clinical departments of supplying PPE. We made sure we had our own supply of PPE, like face shields now. That's a new requirement that we have in our hospital, that all patient contact requires face shields, as well as the other standard PPE equipment. We made sure we were the ones who purchased that. as well as wipes, gloves, et cetera, and et cetera. We can move to the next slide. I want to be very cognizant of time because I also think that the Q&A will be a really fun moment. Just so that you know, I just wanted to paint this picture. Many people don't think of the Midwest as a huge, bustling, thriving area, but I just want to say the St. Louis region, we're busy. We're busy every day. From January through October, I just want to let you know that our hospital, our academic medical center, we've already provided language support in more than 100 languages and dialects. That would result in 46,417 non-English spoken encounters, more than 1,700 sign language encounters, 1,500 international patient encounters. So that's people who chose to come here to St. Louis for their health services. And all that to say is we've had more than 1.5 million minutes of interpreting. Just so you are aware, our top 6 languages were Spanish, Arabic, Bosnian, American Sign Language, Nepali, and Vietnamese. So going back to what Mateo said, we did a lot of translations as well. While our team currently only supports the academic medical campus, we are still part of a healthcare system of 18 distinct hospitals and everything. And when we had to prepare for the pandemic, we also understood that our healthcare system also needed a lot of translation assistance around screening stations, around preparing patients for to understand what visitor guidelines are. And so we made sure that we were part of that conversation to ensure that our top 7 languages across our healthcare system had all of those informations translated. You can also imagine that for many of us, we couldn't ask many of our partner organizations for certain translations because, Bosnian is very unique to our region. Maybe Boston's the only other one who can speak on the Bosnian experience, but we have a high Bosnian population. Much of what we did had to be completed very much to ensure that our Bosnian population was taken care of. Going back to what Mateo said as well, translations was a really big thing for us. 138 projects with 226 translated documents. I have to give a call out to my call center staff. What may be unique to us, which may not be unique to the East and West Coast, but we actually have our own call center. It is not through our hospital, but we have our own language services call center where our physicians, our nurses, our clinical team members call us. We've had 47,000 calls so far this past year. We complete advanced scheduling, on-demand scheduling needs, as well as VRI and OPI concerns. And then one of the things that I just wanted to highlight, many of you may have felt this. I know that many of probably my leadership colleagues have felt this. Since June, we have had pre-COVID numbers every month. We have not seen a drastic decrease in the need for language support, which you can understand would be a huge undertaking for our interpreters, going back to their physical, mental, and spiritual health. And so one of the things that we made sure we very much wanted to keep in the forefront was the health of our team members. And so, we didn't put any restrictions around their use of PTO. We understood that we could always utilize OPI VRI. We understood we could use our agency interpreters. We understood that that there could be a strain on budget, and we also understood that at times the budget was not the #1 priority, but our team members' health were a higher priority because we were thinking of the long-term health effects of our interpreters. We also restricted who they could actually serve and provide interpretation. So we have certain ICUs that are dedicated straight to COVID patients. We don't have our on-site interpreters enter those spaces. Those are VRI, OPI, unless under extreme reasons, right? So if we have very elderly, 90, like going back to what I said, some 90-plus-year-old patients who cannot utilize those services, we will make those proper. We'll make that sure an appropriate visit for that patient. But overall, we try to keep our interpreters as safe as possible. We also make sure that they feel empowered enough that if they are not equipped with the correct amount of PPE that is aligned with what they see their other healthcare colleagues wearing, that they can ask, and if they are not given that they can leave, that they can remove themselves and have that department call us, and we will have that conversation that our interpreters require the same amount of PPE as our nurses, as our physicians, as our care techs. And so we've tried to put that in place. We also try to do our best with limiting how many actual on-site appointments they have during the day. We understand that there's a lot more things happening to our interpreters. We know they're not machines. Sometimes we treat them as machines, right? Do 1 hour here, followed by another hour, followed by another hour. And we also know that this pandemic is not harming just our patients, but it creates a whole lot of pressure that people are thinking of beyond their own healthcare. They're thinking of their families, they're thinking of their own jobs, their livelihoods, and what's happening at home. And so we wanted to create a limit of how many on-site appointments they could take on every day, unless they, right, we understand that there are some wiggle rooms there. We understand that's not a hard and fast, but we wanted to make sure that there were general guidelines about how we protected our staff. Next slide. I'm trying to think of how many slides I have left, because I also don't want to, oh, great, last slide. This is just for people to understand about St. Louis. I love to brag on St. Louis. I'm not from St. Louis. I'm from the East Coast originally, but I love to say that I want to be a St. Louis lifer as long as Barnes Jewish Hospital wants to keep me here. Like I said, we are a refugee resettlement region. We've had multiple waves of immigrant and refugee resettlement periods. Russian was kind of our biggest one. German, French, back in the day, if you know your St. Louis history, Bosnian, Vietnamese, many people have come here. We're also known as the city that has the highest number of Bosnians living outside the country of Bosnia. So many of you, if any of you are football, and I say football as in hockey, soccer, for many of you who are soccer buffs, many of the Bosnian national team was from St. Louis back in the day, a long time ago. Many of the famous Bosnian soccer players had spent some time in St. Louis or had family in St. Louis. In the 1980s was when we were a service started by Jewish Hospital prior to our merger from Barnes and Jewish Hospital. And we were actually called Refugee Health, and I actually miswrote that. It's Refugee Health and Immigrant Services. That was a more overarching support network, and that was before Joint Commission and many of the regulatory pieces came in to protect not only the patients but also our interpreters, to make sure that there was nothing that could put people in harm's way. We also are very proud to have worked closely with our International Institute, which was founded in 1919. And then finally, which may be unique to the Midwest, maybe not so unique to the East and West Coast, we are fully staffed and fully budgeted department under, and we're not funded by foundation dollars. We're not underneath an HR team. We're not part of another nursing team. We are a fully staffed, fully budgeted department under the Office of Diversity, Equity, Inclusion. And so you can see that how we advocate for our patients is not only is it a regulatory need or is that the right thing to do, but it's also a way that we can eliminate health disparities across our region. And for many of us who live in major cities or who are working with geographic diversity, which is something that we struggle with all the time in St. Louis, and that was another piece, and I know Vanessa will talk about it, so I will not take any of her thunder. But one of the other reasons why we chose to keep our staff here was we understood the geographic and the technological diversity of our region, and that we could not rely that every single one of our counties and the people who come from the counties for our service had that reliable internet connection every time for their needs. And so that was another reason. But with that, I believe that's the rest of my slides. And so I just want to make sure that I give space and time to Vanessa and the Q&A. So thank you.
Thank you, Christopher. And I also want to thank you on behalf of folks in the comments who really appreciated the beautiful analogy between the extra mile that your department has had to go and Hanukkah. Quite
Absolutely.
beautiful.
And I just want to reemphasize to everyone, you know, we at BJC always say that heroes work here, and I know that my interpreters are heroes every day. And I just want to stress that each and every one of you who are serving our patients, serving our communities, you are also heroes. So make sure you take that time today, tomorrow, and every day after that. Remind yourself when you see those hero comments that they're talking about you as well. So thank you.
Thank you. Well, before we jump in with Vanessa, Erin, I think we have a couple polls that would
We sure
fit
do.
nicely right here.
Excellent, great. So let's hear more about your experiences then, as those of you who are joining the webinar today, this panel discussion. So since the pandemic began, do you feel safe at work? And we know that the at work might have been a little bit dynamic for you over the past several months. So we'll give you a moment to reflect on that and make your selection. And thank you everybody for your quick responses. We'll give just a few more seconds. It looks like responses are slowing down, so let's see what our results are. We have 22% responding yes, always, 38% most of the time, 26% some of the time, 8% hardly ever, and 5% no, never.
Oh, that's concerning.
Yeah. Let's have another question then to learn about the experiences of those joining us today. On average, while doing your job, how often do you feel you've been offered the appropriate PPE, personal protective equipment? Responses again are coming in very quickly here. I think these will be interesting results as well. Looks like responses has slowed, so we will go ahead and share the results. 45% reporting always, 22% most of the time, 17% sometimes, 11% almost never, and 6% never. Thank you everybody for your responses.
And just a note, thank you, Beverly, that the PPE question is not applicable for those that are working exclusively from home. But for those who aren't, it's important to know if you're getting what you need to feel safe to do a good job when you do your job. Okay, so let's move to the East Coast now, Boston area. Let me introduce Vanessa Foster. She's the Director of Multicultural Affairs and Patient Services at Cambridge Health Alliance, which is a public safety net health system serving a diverse patient population that is 43% limited English proficient. That's a significant number. Vanessa is a core CHI practitioner credentialed by the Certification Commission for Healthcare Interpreters, also known as CCHI, and she currently serves as a CCHI commissioner. She is secretary of the Forum on the Coordination of Interpreter Services, known as FOCUS, and a member of the America's Essential Hospitals Education Committee. Vanessa is a graduate of the America's Essential Hospitals Fellows Program and a 2019 Mass AHEC Tony Windsor Award recipient for language access advocacy. Welcome, Vanessa, and away we go.
Thank you so much, Eliana. And thank you to the 128 attendees who are with us right now. I'd like to tell you a little bit about Cambridge Health Alliance. We have an introductory slide that shows you where we're located. We are a public safety net health system that serves the Metro North area of Greater Boston in Massachusetts. Under one license, we operate 2 hospitals with 24/7 emergency services, 12 primary care practices, 3 teen health centers, 1 urgent care facility, and a public health department in the city of Cambridge. What makes us special is the care that we bring to the people in our communities and who those people are. We're not a particularly large organization, but as Eliana mentioned, 43% of our patients receive care in a non-English language. And that's a higher percentage of LEP patients than any other hospital system in New England. And so very much language access is part of the infrastructure of our organization. The next slide provides an overview of our language access program. The program includes 100 medical interpreters, about 62 of whom are full-time. The rest are per diem or part-time. We also have 200 or so credentialed bilingual providers and clinical support staff who have been vetted and qualified to provide direct care in non-English languages. It's really important, it's a fundamental value at CHA that language access be available not just at all points of care, but at all points of contact. So our language services are integrated and they're built into our phone systems, and it's as easy to call into CHA and access interpreter services as it is to walk in and have an interpreter be present for your needs. We also run many language-specific clinics, programs, and services like diabetes support groups, linguistic and culturally specific mental health programs, and other services. Pre-pandemic, so our last fiscal year before the pandemic, FY19, we completed about 365,000 interpretations across 72 languages. But there are 3 non-English languages that we consider to be the official languages of our organization, along with English, and that's Portuguese, Spanish, and Haitian Creole. Our Portuguese-speaking patient population is about 23,000 strong. We have about 13,000 patients that receive care in Spanish and about 7,000 that receive care in Haitian Creole. Arabic and Nepali are about 1,500 patients each, and every other one of those 72 languages is less than 1,000 individuals. So when you walk into CHA and you look at the signage, and you walk into a department and you look at the materials that are available, it's almost always available in the 4 top languages simultaneously, the official languages of Cambridge Health Alliance. Another thing that makes us unique is that we established the first dedicated hospital-based interpreter call center in New England in 2008. And the next slide talks a little bit about our early transformation and some work we did over the past decade that really set us up for success during the pandemic. So in 2008, we realized that our limited English proficient population was so large and our interpreter request volume was so high, the only way to control cost and quality would be to sit interpreters down and to take our own phone calls instead of routing them out to vendor. And we also looked at, would we be able to provide our own video interpreter services? And so in 2008, we established the first hospital-based audio call center in New England. Within 4 years, we were routinely handling 80% of our major language call volume with our staff interpreters. And what providers told us at that time, and they continue to hold this dear, is that when the interpreter on the other end of the line is a staff interpreter, the encounter is enriched. It's more efficient, it's more patient-centered, more welcoming, and interpreters are able to provide many services, including navigation of patients, to make sure that every patient makes the most of their CHA experience, and they can tap into all of the services and programs that CHA has to offer. In 2012, we were able to integrate video into our internal call center by joining the Healthcare Interpreter Network, which is shared resources of over 30 health systems nationwide. Since 2017, over 90% of all of our interpreter requests have been handled via remote modalities, by phone or by video. And we no longer answer 80% of our major language call volume. It's closer to 60% today because our volumes have increased even as we have grown our department. And I'll tell that story in detail in the next slides. So what this preliminary work meant for us at the start of the pandemic, and I will always remember March 17th as being when my life changed as a language service coordinator. What our preliminary work meant for us is that we already had a mobile workforce. And because we had interpreters working on Cisco phones that could easily be plugged into a home internet router, we were able to successfully transition, with the help of our HCIN tech support, 42 of our interpreters to home within 72 hours of our local pandemic response. And it was an extremely smooth transition. We made it voluntary. We spoke to our campus-based interpreters, we spoke to our call center interpreters, and we said, okay, who wants to go home? Who will feel safer at home? And 42 interpreters raised their hand and said, please send me home. And the requirement was you must take your office phone home, you must have broadband internet at home, and you must have a personal computer through which you can document your interpreted encounters. Just as 42 people said, send me home, 20 campus-based interpreters raised their hand and said, I don't want to go home. I want to stay. I want to stay on campus. And as Christopher mentioned, there are people that feel compelled to be where the action is, to be not just on the virtual front line, but on the literal front line of the pandemic response. Always mindful of those segments of the population that are impacted by the digital divide, that may need in-person interpreter services when they are an inpatient or when they're receiving in-person care. And so it was wonderful to be able to do this largely on a volunteer basis, to have the people that felt comfortable at home go home, and the people that wanted to stay. And we developed plans to make sure that they could continue connected and unified as one team under one umbrella within the Cambridge Health Alliance. There was an overwhelming sense of solidarity with each group saying, you know, we're doing our part to flatten the curve here in this local community that was already a hotspot early on in March. The person in the picture is a wonderful Spanish interpreter, Sarah Krosky. She later wrote a poem about what it's like to catch people between the cracks, which is how she sees her work as an interpreter, particularly during the pandemic. But this is an example of needlepoint. This is her depiction of CHA interpreters pulling down the curve. Some by staying on campus and others by transitioning to work from home. So what's happened since March? The next slide tells a really interesting story that is different than what many of you have experienced in different parts of the country. We did not see a decrease in interpreter request volume. We saw a drastic increase, and it was actually quite shocking to us. Anecdotally, the very first day that our primary care centers closed to in-person visits, our interpreter request volume jumped from 1,300 calls, which was our average for a weekday, to 1,600 calls. And some of that was related to the confusion of patients wanting to know what's going on, what's going to happen to my appointments. But the other piece of that was that we got a lot of people from the community calling in saying, I've lived here for a long time. For example, I've been in this community 5 years and I've never had a primary care doctor. And I don't think I have COVID, but I think I should have a primary care doctor. And so CHA was actually able to accommodate many individuals in the community across language groups as they established care for the first time in the first weeks of the pandemic, which is really something exceptional. So when we look at our fiscal year runs July through June. So this graph shows the FY20 Q3. That's a fancy way of saying January through March. So the blue block is January through March. The red is March through June. And the yellow, or you may see it as green on your screen, is July through September. And you can see how many interpreter requests we've handled in each quarter. Each consecutive quarter has made a consecutive record volume. And overall, at the end of fiscal year 20 in June, we finished with 395,000 completed interpretations, which was already a 10% increase over the prior fiscal year. And if we look at the first quarter of FY21, July through September, we can only imagine what's in store for us in the rest of the year. Our interpreter productivity is flat because there's only so much you can get out of an interpreter without burning them out. And we don't want to burn our interpreters out. So the way we've handled this increased volume is by adding hours to part-time interpreters, utilizing per diems where we can, and also we've seen a tremendous increase, a 29% increase in vendor expenses throughout the pandemic. So we'll be looking, moving forward at, is this volume something that will sustain beyond the pandemic? And if so, how can we continue to increase the number of regular staff interpreters so that we can retain the ability to answer the majority of our calls in-house and provide our CHA providers and CHA patients with the experience that they've come to expect with our in-house call center staff. The next slide talks a little bit about supporting the different groups of interpreters. We really needed to support campus-based interpreters during COVID. They're struggling with the challenges of interpreting with PPE, and many of you on this call now know what it's like to interpret under a procedure mask, under an N95. Some of you may have had panic attacks under masks. I know that I did on at least 2 occasions. In-person interpreters also felt anxiety about whether they would contract COVID, whether they would be exposed at work. And some of them felt loneliness because offices that used to be shared by 3 or 4 interpreters were down to 1 interpreter working on their own. So the supports that we provided were, I made the decision as a director to stay on campus and also to accept interpreter assignments where needed. I actually took overnight on-call schedules so that if a Portuguese interpreter was needed on Saturday and Sunday nights, I would be the one to come in. Our supervisor, Jean Adam, he stayed on campus at our our other hospital, and he is a Haitian Creole and French interpreter, and he actually did all of the interpreting for COVID positive patients himself as his choice to show solidarity with his team. And together we believe that, we would never ask our staff to do something that we weren't also willing to do. And the key to all of us being in this together and being successful is to be physically together. And so we stayed with the on-campus staff. We made modifications to some of the programs that were bedside programs. So for example, interpreter rounds, which is the daily visit to the inpatient bedside to check on how their communication needs are being met. We suspended that program. We no longer did in-person bedside rounds for the first 6 months of the pandemic. And when we resumed the program, we only resumed it for COVID negative patients. Every inpatient is tested upon admission, and so we know their COVID status. But we continued to keep in touch with the COVID positive inpatients by calling into their rooms and by conducting the interpreter rounds and checking on how their communication needs are being met virtually. The other support was to maintain daily huddles, which is something we did from April through August, so that the on-site interpreters and their colleagues who had transitioned to work from home could see each other and remain connected and continue to feel that sense of being one team in solidarity, whether they were on the physical front lines or the virtual front lines. The next slides talk about lessons we learned from what I call our COVID summer. I had never managed a hybrid workforce with some individuals at home and others on campus. And I learned 4 things. One thing is that not all internet is created equal.
Yes.
And our work from home interpreters, to no fault of their own, have really struggled. Sometimes it's because our hospital remote access systems are not fully functional. Sometimes it's because they need to upgrade their personal internet package or their router or some other piece of equipment at home. Sometimes it's because multiple people in the home are pulling from the broadband, or even their service provider variation. Communities that are impacted by inclement weather and the wind blows, and 4 interpreters that live in the same municipality lose their internet access together. So not all internet is created equal, and that's something that we've come to be more accepting of as we continue with a hybrid workforce. The second lesson on the next slide is that staying home does not necessarily mean staying safe. I believe I was naive in March when we sent those 42 interpreters home. We thought, okay, they're home, they're in a safe bubble, and they're not going to get COVID. And what happened was actually the opposite. We've had 3 times as many COVID infections in the work from home group as we've had with campus-based interpreters. And part of it is that we hire from within our community. And so we live in the hotspots that we serve. And so when you live in a hotspot and you share a home with other essential workers who may have to come and go, and you have a large family and your pandemic bubble is large, and you may also be gathering socially unmasked. All of these things were factors that contributed to the higher COVID infection rate in the work from home group. So now we know. I don't know that it would have changed what we decided to do in April. I think that our intentions were noble, and I also think that working from home has been a wonderful experience for many interpreters, particularly the ones that have small children that are also at home doing remote school. But it's not without its challenges, and it wasn't necessarily the health panacea that we thought it would be. The third lesson was that the digital divide also impacts our staff. When CHA went live with the telehealth platform, which is something that didn't exist when we sent interpreters home, we realized, as Mateo mentioned, we're going to have to juggle a few different platforms. It's not just our Cisco phone where we get all of our video and phone calls. Now we need to have computers, and we need to have computers with functional cameras and microphones, and we need to be able to join Google Meet for 3-way video. And the interpreters that have been able to do this have had amazing experiences. On the right-hand side, we see Eliane Noni, one of our Portuguese interpreters, and a social worker, Laura Sharon. And they've had amazing experiences with pediatric behavioral health patients, where the child's on a cell phone, a smartphone, and running all over their house doing a scavenger hunt. And they're opening up to the social worker through the interpreter in ways that they would never have done on campus in a sterile behavioral health outpatient setting. And so, we've really been able to see our patients and to know them like we've never known them before, to get a real glimpse into their home and how they live, to meet members of their family that had never come to the hospital to accompany the appointments. And it's really an unprecedented level of intimacy, and that intimacy has translated for many patients into better care because providers have a better understanding of the challenges that patients face. Our fourth and final lesson from the COVID summer is the importance of staying close. So I mentioned the huddles. We had daily huddles with our campus-based and our virtual groups meeting together for 30 minutes a day in their natural teams. In August, we scaled back to 3 times a week. And the result has been informational because there's been a lot of new information shared back and forth. It's led to an improved experience for our patients and providers, an improved experience for the interpreters, particularly the ones that are at home and need that information delivered to them this way. It's communal, it's also uplifting. Another thing we've done is we've dedicated time twice a month as a group to attend webinars offered by the National Council, the Certification Commission for Healthcare Interpreters, the IMIA, by Masterword. There's so much out there right now where we can learn together about interpreting for COVID, interpreting for trauma, self-care, cultivating resilience, and I think we've done more group learning during the pandemic than ever before as a team. We've also made sure that everyone, including per diems, has the opportunity to tap into the Employee Assistance Program that offers a lot of support services for individuals with work-life balance and other challenges. And we've made time as managers and supervisors to meet in person or virtually one-to-one with interpreters who miss us, interpreters that we miss or that are struggling or just want to talk about something in private. So keep them close is the fourth and final lesson. So my final slide just talks about how we can position as institutions and as interpreters to be successful, to thrive not only during the pandemic, but beyond. Those of you managing interpreter services, invest in a multimodality staff interpreter model. Do it now, build it now. Debrief frequently with co-leaders, with your frontline staff, re-recruit your people, check in on them on a regular basis. If you are thinking about a call center, this is the time to build it right with the appropriate setup for physical distancing, for visual privacy, for auditory privacy, the right ventilation. You may consider, having small teams in multiple locations and not everyone on top of each other. This may be the opportunity to build it right from the ground up. And also, as you're launching telehealth platforms, get to the table. There was a politician who said, if they don't reserve a seat for you, pull up a folding chair. Because if language access doesn't get integrated early on, it's going to be a whole lot harder to do it later. And then finally, this is a great opportunity to connect with patients where they are and ask them, how can we improve your experience of care? Our CEO has been talking a lot about the pandemic as being a time to recognize what served us well and to let go of the things that didn't, and to build a better CHA. And I think each institution can do this in collaborations with patients, with community partners, and with staff. So a final thought for you is that language access will continue to be essential. More than ever, I think that the pandemic has opened up new opportunities for interpreters, for language programs, and for LEP patients. And I think that the future is bright for all of us and that we can continue in this together. We will survive and we will thrive.
Thank you so much, Vanessa. And there is a lot to learn. I've had to pivot to teaching online as well as interpreting online. And one of the things I noticed in the teaching was how many students join the class on their smartphone, which is a whole lot harder to navigate whatever application you're using or whatever platform you're using than a tablet or a laptop or a computer with a bigger screen where you can see where the controls are. So everyone who has worked with their community to assist with that, kudos to all of you. And I've collected a few questions. Are there any other polls, Erin? I lost track. I don't think so. Okay. So first question, how do you coordinate Zoom services with your members and patients? When do you give them, for example, the Zoom ID so that they know how to get onto the platform? And this goes out to any of the three of you that wishes to respond. How do you get your patients on the platform?
So I could talk a little bit about CHA. We're using Google Meet as a telehealth platform, and there are different ways to access it. We experimented. We actually were able to be the first organization in the country to integrate Google Meet with Epic and MyChart, so that the patient could log into MyChart, enter a portal, consent to treatment, and wait for their session to begin. What we realized is, as beautiful as that was, and it was accessible in 4 languages, patients still struggled with logging in to MyChart. And so we have alternate ways of joining the Google Meet. You can access it through a link that is sent to your email or to your cell phone as a text message in advance of your appointment. But we've provided a lot of support. There's a hotline for patients. Interpreters are integrated into that hotline to help them as they're downloading apps or as they struggle to find the link or if they're having technical issues with their devices.
Awesome. Mateo, we showed the website that had the orientation for how to join on your phone and tablet, and that is so key. Chris, Mateo, anything you want to add to that question? Doesn't have to be in Zoom necessarily. How do you help orient your patients to get to the place where they can make that telehealth appointment?
Yeah, I guess I would just add that we have 2 ways of accessing the telehealth appointments. One is what we call the integrated, which is through the MyChart, like Vanessa just mentioned. And then the other is for the patients that don't have MyChart. And unfortunately, MyChart has been traditionally only in English. We are now starting to add Spanish to MyChart, so more and more of our LEP patients can take advantage of that. But primarily through the instructions that we've produced in the top 10 languages.
The next question is, what has everyone done with the problematic negative pressure rooms? The fans are so very loud and it makes it very difficult to hear when you're doing OPI or VRI. We've had to move back in time and connect adapters and extra handsets to our analog phones in the patient rooms. Do you have any other ideas or suggestions to cope with the situation?
That is a great question.
Mm-hmm.
Yeah, we have been getting complaints about connectivity issues and audio cutting in and out from our interpreters. One of our supervisors, Rosa Arce, and I have done some test calls, and it seems like a lot of the problem is background noise and the microphone kind of not knowing which sounds to focus on. But yeah, we haven't come up with a great solution for that yet, except just as interpreters being a little more assertive on what we need when we're working remotely, making sure providers and patients are closer to the machine, are speaking up, things like that. But as far as a technological fix, on the interpreter side, they're great, like noise canceling microphones, directional microphones, headsets that control spikes in volume so that you can reduce the possibility of shock to the ears. But on the other side, yeah, I don't know. Vanessa, do you, or Christopher, do you guys have any?
We haven't found a perfect solution, but we have experimented with external microphones. So you may be able to pair a Bluetooth microphone to your device, or even a wired microphone that perhaps pins to a lapel. And of course, you have to clear everything with your infection control people. But the best solution I heard so far doesn't come from my organization. It comes from Gorkan Silam, who's the manager of interpreter services at Holyoke Medical Center. In her physical therapy department, a very intelligent therapist took a wireless mic, affixed it inside his mask, and paired it Bluetooth to the device so that his speech is very, very clear. The interpreters hear it. Of course, they also hear all the heavy breathing, but they can adjust the volume. But with the mic on the inside of the mask, he makes it work. So be creative in concert with your infection control people and see what you can do within your organization. You may surprise yourself. I think all of us are a little bit MacGyver right now.
Yeah.
And I think for me, the only thing I would add is really working with your infection prevention team. For us in those negative pressure environments, sometimes we have our interpreters go in, and that's very much be very careful where you position yourself from a physical distancing, but just being louder. And then there's that. From the technological standpoint, our VRI machines have external speakers, and we just make sure that those pass through infection prevention, and we make sure that we have educated our nurse and physician teams to place them in ways where you can reduce the noise as much as you can, but also knowing to really look at the cues of the patient, that it may be you just need to finagle a bunch of times until you find that correct that correct positioning of the triangle you'll need to do to make sure that everyone can hear in a way that doesn't reduce the patient experience.
Yeah, I guess I should add one thing that we have done in like infusion, pre-op, post-op. We've actually added dual handsets to the iPads. So that works if it's just the patient and the provider. There's a handset for the provider, a handset for the patient, so they can see the interpreter on the screen still, but they have the voice and sound right there at their face.
That sounds like an excellent solution as well.
It works for areas with
like your
open
analogy.
bays.
We're all MacGyver right now. So, question from an ASL interpreter. What type of PPE masks are you using in your hospitals for sign language interpreters? Is there a specific brand that works well or that you recommend?
Great question. So our sign language interpreters would get the same PPE that our providers would get. And unfortunately, we don't have any staff sign language interpreters right now. But along that same vein, we have had, like I mentioned earlier, we've had some challenges for our patients that do not use sign language who are deaf or hard of hearing because everybody's masked.
Right.
So in those cases, we do have some see-through clear masks with like anti-fogging agents on them so that they don't fog up, so that you can see the face of the providers and you can read their lips.
Our infection control liaison determined that the safe and clear mask for us would be the equivalent of the protection provided by a procedure mask. Of course, procedure masks are only for use with patients who are COVID negative. For patients who are COVID positive, we absolutely need to be wearing the N95. So there isn't a clear mask alternative to the N95. Thankfully, we have not had any COVID positive inpatients that communicate with ASL. We do have a staff interpreter, but any COVID infections have been managed outpatient. We have a wonderful community management program that is helping most COVID patients get better at home without the need for hospitalization.
So for us in St. Louis, our infection prevention team, as well as our sourcing teams, they have made Safe and Clear and the Clear Mask available for order, whether our nursing teams want to order it, whether we want to order it. We have had those orders. Our ASL interpreters have used them. Of course, it comes with probably all the concerns that everyone else has brought up by using it, right? It fogs. It's probably not, while some of them are FDA approved, it does not actually meet the muster of an N95 or things like that. And so what's really been interesting, and I'm not sure if it's really a solution, and I also wouldn't want to rely it as a solution, is that we have quite the dynamic and very invested deaf community in our region. And they're actually working together as a community to actually create and develop their own masks for interpreters, right? We've had quite a few deaf patients actually give masks that they've made to our ASL interpreters, trying to find ways to help create that area where people can see the emotions, they can see the lips moving, because we know that for many people who are deaf, hard of hearing, and I know I'm preaching to the choir, it's not just the physical motion of your body and your hands, it's how you express yourself with your facial expressions and things like that. And so, unfortunately, I don't have a good answer. you know, it's something we're working on, and I am very certain that 2021 may have a lot of opportunities for that to come through. Just like how just standard masks are improving every month, I can imagine that clear masks or masks that can help our deaf and hard of hearing patients will also continue to improve as we do more research.
Awesome. Vanessa, this question came up for you right after you mentioned how many bilingual providers there were. And the question is, regarding your language access program, what is the difference between the medical interpreters and the credentialed bilingual staff?
So the credentialed bilingual staff do not interpret. They are not qualified to provide interpreter services. They have been qualified or vetted to provide direct care within the scope of whatever their role is in a non-English language. So an example would be a Spanish-speaking nurse who has been vetted for Spanish language proficiency and will use Spanish in the provision of nursing care within her scope, but she's not qualified to interpret for other clinicians.
Mm-hmm.
Yeah, and that's the same at UCSF also. There are institutions that have what they call dual role interpreters, where they will certify and train staff who have a primary job and then also step in as interpreters. But it sounds like Cambridge Health and UCSF, we do not allow that. We certify providers and staff only to provide that direct care, but not to interpret for third parties.
Mm-hmm.
They really are different skill sets.
Yep, and that's exactly right. So that is an opportunity we are actually exploring. And Vanessa and Mateo said it correct. One of the main guardrails that we have to always consider is that a bilingual provider is not an interpreter. And so many of those guardrails are, if that person is assessed and is deemed able to provide service in a different language with the patient, that is something that is only between that patient and the provider. If there's another professional in that room who is not bilingual, if there's a family member in the room who is not bilingual, then that is now a moot point and an interpreter is required. So, we also understand that we also have to be very careful around ethics and pieces like that. And so, that's something we're exploring with our colleagues, and we're being very slow and deliberate about what that needs to look like.
Well, I'm gratified to hear that you're all on the same page. When I was at Harborview, we did the same thing. We would assess providers, but they were limited to using the other than English language within their area of specialization. So the Somali-speaking phlebotomist could tell the Somali-speaking patient to make a fist, to open their hand, or that they were going to draw blood, but they couldn't be poached to go to the peds clinic next door for a Somali mom and her baby. No. Just within your job description, and interpreting reserved for interpreters. So hooray to everyone.
Yeah.
And yet the value of that credentialed bilingual workforce has really been underscored throughout the pandemic because they have made it possible for us to, for the most part, keep interpreters out of the rooms of COVID positive patients because they have been able to provide so much direct care directly in the patient's languages.
And this one rounds again back to you, Vanessa. And you spoke about the demand for interpreting shooting up, but placing limits on the number of hours that your staff interpreters would work. The question is, what was your practical limit for daily appointments?
Well, that's actually a question for Christopher.
Oh, okay, sorry.
So like I said before, we did not, at the very height of it, at the right, that early summer, late spring, at least in the Midwest, when a lot of things were shutting down, our own hospital started canceling elective surgeries, started postponing surgeries, really restricted clinical outpatient appointments and things like that. That was really the only time we actually saw a dip in language access need, because we weren't allowed, patients just weren't allowed to be there. But the moment it was lifted and we went back to, full services, we shot right back up to a point when this is where that mental health and spiritual health and physical health comes in. You are now running at the same level pre-COVID, but with COVID. You know, it's, you know, you're basically trying to do everything you did in 2019 with this really scary disease hanging over everything that we do in our hospital and in our communities. And so what we did was we kind of looked at practically, you know, what would have been a normal workload in 2019 for an interpreter, and then we severely limited to what that would then look like every day for an interpreter. So, you know, I'm not, you know, it's never going to be a, you know, I'm not going to write it in, we're not going to write it in stone. But what it could look like for one day is if we have a Spanish interpreter and our schedule looks really, really busy, we will not add more than 2 in the morning, 2 in the afternoon. You know, if it's, you know, a morning consists of 4 to 5 hours for an interpreter, we probably would limit the amount of interaction they'd have with patients to 2 appointments. Sometimes that's based on time, and sometimes it's based on acuity of the patient. And that goes back to the idea of we understand, you know, we're trying to understand risk. We're balancing it with the health of our patients, the health of our interpreters, and also knowing that, you know, if there's a budget concern, that's something we need to justify and say, you know, the health of our interpreter sometimes will supersede a budget concern that we went over this month, because, you know, we're not going to drive our interpreters into the ground. It's not good for them. It's not right for us, and it would actually be against our own mission of our own hospital of taking exceptional care of everybody. You know, and when we say we take exceptional care of people, our interpreters are still people, and they are at the forefront of the minds of my team and my department. So, you know, sometimes it could look like, you know, we assign 2 cases for our ASL interpreter for the whole day, and the rest of the time they're working with our clinical team members on determining how best can we do other forms of communication with our deaf, hard of hearing patients in ways that don't always need to have an ASL interpreter present. I know that's not always the best way, but we also know that we can't, that at least in the region, I'm not sure if San Francisco and the Boston and the Cambridge, Boston area have this, but we have a severe shortage of certified ASL interpreters who are level 4, level 5, or master interpreters who can actually provide medical interpreting. And so, you know, we need to find those mechanisms in place where we can still communicate with people and also honor their own empowerment. We have patients who refuse it, and so then we have to be ready for, how do we communicate with you once you refuse? And so for us, it's, you know, that's how we try to strike the balance. I will say not every day do we strike it well. Some days, you know, we ask a lot out of our interpreters, and I am eternally grateful, you know, for the size of the heart of an interpreter.
Absolutely. I think interpreter productivity is a webinar of its own.
Yes.
Yes.
But I agree with what Christopher said. It's just like before COVID, only with COVID. So our interpreter productivity expectations have not changed. We use a productivity measure that looks at an 8-hour workday. And if you take out lunch and breaks and your half-an-hour daily huddle, that leaves you with 6.5 hours. So we look at what % of those 6.5 hours the interpreter is actually interpreting, and that's the productivity. And we have a department-wide average of 76% productivity.
Wow.
And
That's
that has
incredible.
not changed during the pandemic, but it feels heavier now because of COVID, because of the nature of so many of those encounters. And that's why we're taking more time throughout the month to debrief, to engage in learning, especially learning around self-care, around resilience, and around how we can continue and not burn out, given the emotional weight of the interpreting that we're doing during this pandemic.
Very good. The next question says, I'm not sure if they meant if or in pre-pandemic times, the ratio of in-person to remote encounters was at least 2 to 3. What do you foresee as the new normal ratio going forward?
So I will probably answer it with a more 30,000-foot, probably aspirational answer. I actually think this is a great opportunity to expand how you can support everybody. You know, I think when we at BJH were thrust into this very quick, very fast, find solutions to support people now that they can't be here, or to find different ways to support them. You know, that was a very much, you know, adrenaline kick and we had to find an answer. But I think when we review what we were able to accomplish in 2020, I think that does, going back to Vanessa's, some of what she said, that I think that can help us span the digital divide. It can help us span the geographic divide. Now that we have these tools and resources available, we can now empower patients, family members, physicians, nursing teams, as well as all departments to say, what is the best way for you to communicate with your patient? And can we allow our patient to now be more empowered to determine how best they would like to communicate with us? And now we actually have that ability to do that instead of, and I won't say that this is something we've done, but I could imagine maybe in 2019, 2018, many of our organizations that you've worked for, that I work for, forced patients to come on site. Like it was a non-starter for you to refuse. You either came on site or they would cancel your appointment,
Right.
or you had to do it a certain way. And I think this may give that opportunity to our patients and many of our underserved communities. They have more voice in their determination of how they would like to receive their care. And I think that will give our interpreters more opportunities to, and I'm going to keep stealing what Vanessa talked about, gives them that ability for professional development to be a more well-rounded interpreter and understanding, man, I'm not just a proficient and great on-site in-person interpreter. I'm an exceptional audio OPI interpreter. I'm an exceptional VRI interpreter, man. I can teach anybody Zoom at this point, right? And so now, and I think it may give interpreters more than just a folded seat at the table. They can come in and say, I'm actually truly an expert in communication and dissemination, and that this is what I think may be best for us right now. And I think that is going to be a true opportunity for interpreters and for language services teams to really push forward in 2021.
Yeah, I so agree. I think gone are the days of the interpreter specialist who only does face-to-face or who only does remote. All three modalities will survive the pandemic. There is room for all three modalities. And what we need are interpreter generalists who are willing to stretch their skill set across modalities.
Yeah, I agree. I think that I've always said that I don't think it's so much the mode of interpreting, it's more the quality of the interpreter.
Yes.
A good interpreter can work well in person, over video, or over the phone. In terms of the future, what the future brings, I really feel like we were on this trajectory already before COVID. At least here in the Bay Area, we have patients coming to UCSF from all the way up at the Oregon border, which for those of you who don't know California geography, that's like a 6-hour drive. Dealing with traffic, parking, bridge tolls. I mean, parking is like $35 a day at UCSF, and we do the best we can to keep that price low, but things are expensive here. There's a lot of traffic. We've had interpreters asking if they could work at home a couple days a week to avoid commuting for years. And I feel like COVID, what it's done is it's just basically pushed us light years into the future in terms of this. Like VMI, we're using telehealth for everything now, but I think over time, we will realize where and when it's more appropriate and where and when it's really worth that commute time. It's really worth getting up, for a patient that lives in Fresno at 5 in the morning to get to a 10 a.m. appointment. Things will balance out again, but I don't think we're going to be going back to the way it was before. And I just kind of wanted to piggyback onto that idea. I thought it was really interesting what Vanessa said about her home interpreters having greater infection rates than her on-site interpreters. Luckily at UCSF, we've had 0 infections among our interpreters. But what we have noticed of the staff, and I think this is across the board, is where staff is getting infected are in break rooms and carpools. So when they're on site working, they're actually protecting themselves. But when they're in the break room eating lunch together and things like that, or sharing a carpool to and from work, they're getting infected. And that's where I think the remote work mode has really helped us out, at least here in California.
Well, there's still so many wonderful questions, but we have 1 minute left. So I'm going to have to close here and get in a couple of announcements very quickly, so I'm going to speed up my rate of speech. Just a few announcements before we end today. As you leave today's webinar, you'll be directed to an evaluation form to provide your feedback. If you're not already a member of NCIHC, we encourage you to join this organization whose mission is to promote and enhance language access in healthcare in the US. For those of you who are members, thank you. Be sure to visit NCIHC's website for more information, and feel free to send general email inquiries to info@ncihc.org. On behalf of the National Council on Interpreting in Healthcare, I thank you from the heart, Mateo Rutherford, Vanessa Foster, Christopher Fan, for today's wonderful panel presentation. Right back at you. Thank you as well to everyone who attended today. See you in January for part 2.
Thank you. It was an honor.
Yes, thank you. Thank you all.